for me to be able to give this lecture. My name is Eric Brown. I'm an associate professor at UC San Diego. I have also the pleasure of working with Dan Skanderbeg, who spoke with you last week and will speak with you again coming up in a couple of weeks. I did want to mention right off the bat, it would be good if we could make this presentation a bit more of a conversation than just me sitting here telling you information. So if at any point you have a question or a comment or something's not clear, please just feel free to interrupt me or ask a question, and we can go from there. I'm also going to try and ask you guys some questions, and if people could just jump in and try and answer those questions, I think it'd be a lot more engaging and a lot more interesting for all of us. Does that sound good? Okay. So today we're going to be talking about cylinder treatment planning, insertion, and treatment delivery. This is an image I also got from Dan Skanderbeg showing the female anatomy, and primarily what we're going to be treating is the vagina. So here's an outline for the presentation today. I'll just give you a brief overview of what a cylinder is, what we use it to treat, and why we like it. We'll talk a little bit about how to commission a cylinder from the physics perspective. We'll talk about pre-planning. Cylinders are particularly well suited to pre-planning, and it's a really great option because you can essentially avoid having to use imaging. We'll talk about planning aims and prescription. We have a standardized way of doing this. So this is how we're going to plan and prescribe all of our treatments. Talk about the insertion, things to think about, imaging if you are going to use imaging, how to connect and measure for a cylinder treatment, how to perform the delivery, and then some sort of special considerations for when we are treating cylinders. Okay, so here's what a cylinder looks like. I think many of you will probably already have this in your mind. It's essentially a single central channel, and then on the right side of the image here, you can slot onto that single central catheter different sections that are cylindrical. So you can change the length of the cylinder by adding more sections, and you can also change the width of the cylinder just by using sections that have a different diameter. So it gives you some flexibility in how long the cylinder is and how wide the cylinder is. But again, we're treating with just one single central catheter. So primarily cylinders are used to treat endometrial cancer, almost always after a hysterectomy, which means the uterus has been removed. So if you look at this image on the right, I'm not sure if you can see my mouse or not, but this patient has had her uterus removed, and now we're treating endometrial disease that may have come down from the cervix into the vaginal wall. And that's really the goal of treatment, is to treat the tissue immediately beside the cylinder. And we're usually going to prescribe to a depth in the tissue from the surface of the cylinder of 0.5 centimeter, so 0.5 cm. And you can see in this image, this is a CT image, a coronal slice, and we have this single central catheter running down the middle of the cylinder. Any questions so far? Okay, so commissioning, actually relatively easy. Again, we have just a single central channel. So as with all commissioning procedures, we're going to start with a visual inspection. And then our primary source of commissioning here is going to be to use GAF chromic film or some other type of film. It doesn't have to be GAF chromic, it's just that GAF chromic is very easy to use and gives you immediate results. But you could also do this with older style film as well that you would have to then produce in a darkroom. So what we're going to use that for is to ensure that our planned and delivered lengths match. And the strategy for this is going to be to take that central channel of the cylinder without any of the cylindrical sections on it, and tape it onto the film. I think I have an image of this. So if we imagine this blue square is a square of film, and we're going to take our central channel, tape it onto that film, and then deliver 10 to 15 seconds in each of 20 dwell positions, so something like 6 centimeters long. And then we can mark on the film where the tip of that channel is, and we can look and compare to what we get on the film. And of course, that should match. So if you look here, where we've taped that central channel, matches almost exactly where the delivered dose is. So for this, we would be happy. If we had taped it here, we planned a specific length and then delivered it, and we got this dose distribution, this of course would not be good, right? Because we're not treating to the end of that central catheter. Any questions about that? Fairly clear? Okay, and that's really our primary source of commissioning the physical components of the delivery for a cylinder. As I mentioned in the introduction, cylinders are ideal for pre-planning. The reason they're ideal for pre-planning is that they have a completely fixed geometry, right? It's a single central catheter. We're always going to use the same length and the same width for each of our patients. So it's ideally suited for pre-planning. The only thing that changes is the diameter of the cylinder and the length of the treatment. Some of the benefits of pre-planning: it's extremely efficient because it's very, very fast. You don't have to image and plan every treatment. It's extraordinarily safe, again, because you don't have to image and plan every treatment. And it's definitely your best option for a cylinder. And Adam and Ben have actually created a bunch of pre-plans that are already available to you. So these are for specific cylinders and specific manufacturers of cylinders, but you can sort of get the idea here. So this is what a pre-plan would look like. Have dwell position on the left, so running from 1300 millimeters to 1270 millimeters. And then you have different diameters of cylinders, 20 millimeters running all the way up to 40 millimeters. And then in the central part of the table, you have all of the dwell times that will give you an ideal dose distribution, having the 100% isodose line 5 millimeters from the surface of the cylinder. So if you had the same equipment as this, you could actually use these dwell times and they would give you a good result. Something? Yep. Does someone have a question? So something interesting to look at here, and we're going to see this in all of our cylinder pre-plans, is that you have a lot of dwell time at the distal end of the cylinder and a lot of dwell time at the proximal end of the cylinder. So if we're looking at the 20 millimeter cylinder, at the tip of the cylinder, we have dwell times of 19, 41, 26 seconds. So that's quite a lot. And then at the proximal end, we also have large dwell times, so 11, 31, and 42. And then in the middle, we have relatively small dwell times, 2 seconds or 4 seconds. And we call that, if you look at it in a different view, this is a similar sort of setup. Again, we have position and the amount of time in each one of these positions. It's represented graphically. We would call this sort of an hourglass shape. So can anyone tell me why we would have a lot of time in the tip and the proximal end of the cylinder and not very much in the middle of the cylinder? Again, remembering that the goal is to treat uniformly 5 centimeters from the surface of, 5 millimeters from the surface of the cylinder. Does someone want to have a guess at why we would have this sort of dwell time distribution? Anyone? Nobody, come on. Okay, so the reason we have that is because the middle of the cylinder receives dose contributions from the dwell positions all the way along the cylinder, but those at the tip and the bottom of the cylinder only receive contributions from a few of those sources. Does that make sense to everybody? So in order to get an even distribution, 5 millimeters away from the surface of the cylinder, we need to have a lot of dwell time, a lot of time in the tip of the cylinder and the proximal end of the cylinder, and then not so much in the middle, because that middle section is getting dose contributions from all of the sources along the cylinder. So here is what our dose distribution is going to look like. This is an ideal scenario for us. So we have here on the left a diagram of the cylinder. The lines in white are outlining the surface of the cylinder and the central channel of the cylinder. The green line running down the central part of the cylinder is where someone has digitized this, meaning electronically they've said this is where this source positions can go in this cylinder. And then what we see are 200% isodose line and 100% isodose lines in red for 200% and yellow for 100%. And we're going to use the following terminology. So you can see the 100% isodose line is essentially running uniformly. The goal is for it to be uniformly 5 millimeters away from the surface of the cylinder. And that you can see with this distance measurement right in the central part of the image. And the following terminology we're going to use, we're going to call this the planning aim length. So the planning aim length is from the very distal end of the 100% isodose line running to the point where the 100% isodose line crosses inside of the 5 millimeters distance away from the surface of the applicator. That's shown by this red measurement on the very right side of the image. So in this case, we would have a planning aim length of 3 centimeters. And the reason we're using that terminology is because that's essentially the length of the treatment where we are sure that we are covering 5 millimeters from the surface of the cylinder. And the reason this is important is because that's how we're going to prescribe our treatments. So this is important for the physicians to understand that their dose prescription must include a planning aim length. And that's really going to tell us how far down the vaginal wall they would like that 100% isodose line to run. So very important point here that all dose prescriptions must include a planning aim length. If they don't include a planning aim length, or if someone doesn't have the same understanding of what planning aim length means, then the treatment will be for sure suboptimal. And the radiation oncologist will not be getting the dose that they want at the length that they want it. So very important that you go over this with your radiation oncologist, that you understand what planning aim length means, and also that they understand what planning aim length means. Any questions about that? Because it's quite an important point. And it's also a great way of standardizing terminology for these cylinder preplans. Because we're treating from the inside of the tumor to outside of the tumor, as we are always doing in brachytherapy, it can be quite easy to overlook hot spots. So we're going to try and avoid that. And our rule of thumb for cylinders is that we definitely want to keep the 200% isodose line within the cylinder. And the reason we want to do that is because anything above 200% in tissue could lead to tissue necrosis. So with all of our brachytherapy applications, it's going to be really important for us to try and sort of minimize the really, really hot spots. And it can be quite easy in brachytherapy to concentrate a lot on the 100% isodose line and ignore those really, really hot spots. And it's actually easier to have 100% dose distribution that you're really happy with if you're willing to have large hotspots. So it's often a compromise that we have to make, is to try and minimize the size in terms of volume of the really, really hotspots, say 200% isodose plus. And that sometimes means we're going to have to compromise what our isodose distribution looks like. For cylinders, this is an important point to remember, but typically not a major issue. Again, because we're pre-planning, we're going to want to make sure that all of our plans are done really, really well. So we'll use an independent check of the dose calculation. Something that's kind of interesting to do if you have the time is to, on your own, recreate TG43 in an Excel spreadsheet. It's actually not that complicated to do. If you're not interested in doing that, we have second check spreadsheets that you can use to check the dose distribution of your pre-planned cylinders. One thing I just want to comment, I think this comes up later in the presentation as well, but it's a really important point. Pre-plans are a fantastic option, and they are definitely the recommended option for cylinders. You don't have to plan for each patient. You don't have to take the time to plan. You don't have to have the chance of getting it wrong. So it's a lot faster and a lot safer if, and this is a big if, it all hinges on the fact that your plans are correct. So if you generate a series of pre-plans, or if you use a series of pre-plans for a different device and something is not right, then that means that every one of your patients that you treat with that pre-plan will have a suboptimal plan. And you likely won't catch it once you have commissioned and checked the plans. You can just start using them. And that could have a really huge impact on your patient population. So while an accurate, good quality pre-plan is incredibly safe, if that pre-plan is incorrect to begin with, then every single one of the patients treated with that plan gets a suboptimal plan. So really important that you want to spend a lot of time making sure that your pre-plans are accurate for your cylinders. Does that make sense? I think everyone sort of understands that point, but it's just really important to make sure that everything is in order. In terms of insertion, this is probably more of a physician-driven decision, but it's also an easy concept for us to understand. Essentially, what we want to do is choose a cylinder diameter that is just smaller than what the patient can tolerate comfortably. Does anyone have any guesses why we would want to choose a larger diameter cylinder as opposed to a small diameter cylinder that may be more comfortable for the patient? The reason for, yeah, sorry, go ahead.
To remove the air between the tissue and the cylinder, or to remove the space. If you
This is absolutely correct, and thank you so much for contributing to the discussion. That's exactly right. If we used a smaller cylinder, we could end up with small sort of air gaps. And you see that a little bit here on the image on the right. If we use a larger cylinder, then we stretch that tissue out, and we essentially get rid of those air gaps. If we do have air gaps like that, you can see in this image, we're actually going to underdose the tissue, right? Because the 100% isodose line is going to run essentially through the middle of that air gap, and the tissue that we want to treat is going to get far less than 100% isodose. So thank you again for that answer. It's exactly right. We're looking to minimize air gaps between the cylinder and the vaginal wall. So this does not mean that you have to choose such a large cylinder that your patient is going to be in a lot of pain. Of course, we don't want that. We just want it to be as large as is tolerable by the patient, so as much as they can tolerate it comfortably. In terms of imaging for cylinders is essentially optional. If you have easy access to imaging and you have time on your CT scanner, then it's a good idea to check that there are no air gaps. I don't know of anywhere that images every single fraction of a cylinder. I do know of places that image the first fraction of the cylinder. Again, the reason for that is essentially just to check for some sort of significant air gaps between the surface of the cylinder and the vaginal wall. Most places, again, will not use imaging for cylinders. We're using pre-plans, so we don't need to digitize every single time we treat. So we can definitely treat without imaging because we're using pre-plans. Once the cylinder is inserted, just like we're going to do with all of our brachytherapy treatments, we're going to manually insert a dummy wire. So this is a wire that essentially mimics the radioactive source wire, but it doesn't have any radiation. And we'll use that to measure the length of the transfer guide tube plus the cylinder. Why would we want to do that? Let's say we only have one length of cylinder and one length of guide tube. I would recommend, or we would recommend, that we still do this length measurement. And what's the reason for that, to do that every time? So it is time consuming, but it's a really worthwhile thing to do, essentially for two reasons. The primary one is that it allows us to check the connection between the transfer guide tube and the central channel of the cylinder. If that connection is not complete, then we could run our source out into that area. It could get stuck and we could have a lot of problems. So it's really nice to be able to run the dummy wire through the transfer guide tube all the way to the end of the cylinder, because it allows us to check that that connection is secure and appropriate. Another thing that it allows us to do is to ensure that our pre-planned lengths are correct. So in some institutions, in some clinics, we will have multiple different lengths of transfer guide tubes. And if we have that, then for sure we want to measure the length every time to make sure that we're using the correct pre-planned length. So two reasons to do this. It is time consuming. Well, for a cylinder, it's not really time consuming because you just have one measurement. Once you have multiple catheters, it can become sort of time consuming. But for a cylinder, and for all of our treatments in brachytherapy, a very worthwhile thing to do. We do this in our clinic before every single treatment, and we do find times where the connection between the transfer guide tube and the catheter, whatever catheter we're connecting to, is suboptimal. And it's better to find out before you try and run the radioactive source through that connection. Treatment delivery, as again with all of the treatments that we do in brachytherapy, we're going to perform a timeout immediately prior to treatment. You can include many things on your timeout list, but at the very least, we want to ensure that we have the correct patient. In a busy clinic with lots of stuff going on, it can be surprisingly easy to bring the wrong patient, insert the cylinder into the patient, and then treat that patient. So immediately prior to delivering the treatment, we want to check that we have the correct patient. Very important is that we want to check that we have the correct cylinder diameter. Again, we're using pre-plans, probably most of the time not with images. So we're going to need to make sure that we have the correct cylinder diameter, that we're treating the correct dose, that everyone has the same understanding of what planning aid means and where the dose, 100% isodose lines, and that the room is clear. I think on the next slide, I just want to make a point. Maybe I'll make that point here. I think it comes up again later in the presentation. If it does, I'll skip over it. Why is it so important that we have the correct cylinder diameter? Does anyone want to chime in on that? So let's say we have a pre-plan for a 3 centimeter diameter cylinder, and we insert a 2.5 centimeter diameter cylinder. What is the result going to be? It's going to be pretty severe for the patient because the 200% isodose line will almost certainly then be in the tissue. We're going to severely overdose the patient. And the same thing happens if you go the other way. So let's say we have a 3 centimeter diameter cylinder pre-plan, but instead of 3 centimeter diameter, we insert a 3.5 centimeter diameter cylinder, then we're going to severely underdose the patient. Because we don't have imaging, there may not be a record of this. So again, just a very, very important point, something that I always concentrate a lot on and double check and triple check with the radiation oncologist who does the insertion of the cylinder is that we get the right diameter of the cylinder. It's relatively easy to get wrong because we're not imaging. There may not be a record of it, so we won't be able to correct the dose if we have done something wrong. So just an important point to keep in mind. The diameter of the cylinder is sort of really crucial to getting accurate treatment delivery for cylinders. Okay, important things to consider. I think I said this already, but pre-plans must be of high quality. Why is that? Because if we get them wrong, then we're going to use the same plan for each one of our patients. And that means that each one of those patients treated with the incorrect plan is going to have a suboptimal treatment. So very important to spend a substantial amount of time up front when you generate those pre-plans to make sure that they are accurate. Again, you can make your own Excel spreadsheet to ensure that they are accurate. We have Excel spreadsheets that you can use as well to make sure that they are accurate. Length measurement is important, especially if you start using different transfer guide tubes. Transfer guide tubes can also stretch over time, which would change their length. If you continue to use pre-planned lengths and your transfer guide tube has stretched, let's say it's stretched maybe 3 millimeters, then the treatment is going to be 3 millimeters more distal than you would like, and you're going to underdose the tip of the cylinder. So again, just a great idea to check the length measurement before any of the treatments. And this is just the same point about cylinder diameter. Very, very important that we use the correct cylinder diameter. If we get the wrong one, and we're using a pre-plan, then we get a suboptimal plan. And this is the same description that I talked about earlier. And I think that's it. Does anybody have any questions, comments, anything that I didn't cover that you wanted to know about cylinders? Any comments from the folks from RCC? Okay. Well, I guess that's it. I think tomorrow we're going to talk about tandem and ovoids. It will be a little bit more involved because the planning is a little bit more complicated. And there we do need some sort of imaging. The reason for that is that the geometry is not a fixed geometry, which means we need to have images and find some way of digitizing each one of the catheters in the tandem and ovoid. So I have a strategy that I use for that I'm going to describe for you guys tomorrow. Sound good? Okay. And with that, I guess I'll talk to you tomorrow at the same time. Bye, everyone.
Thank you very much. Thank you.